Good morning. This is a lecture on chapter 35, which for digestion is the liver, gallbladder, and the pancreas. So let me share my screen and let's get started. All right. So, chapter 35, liver, pancreas, and gallbladders. What are we going to talk about? We are going to discuss the causes, the risk factors, and the pathophys of different types of liver disease, therapeutic measures for liver disease, the nursing care, what the risk factors are, and the pathophys of pancreatic disorders. Same thing, therapeutic measures, nursing care, and then the same thing for the gallbladder, okay? So let's start with hepatitis. The word hepatitis is just inflammation of the cells of the liver, okay? So it's not viral hepatitis, which we're going to talk about, but it can be. So in other words, the word hepatitis is just inflammation of the liver. Can be caused by a bacterial infection, can be caused by drugs, alcohol, chemicals, anything that's toxic to the liver, metabolic or vascular disorders, but it's often caused by a virus. Hepatitis A, hepatitis B, hepatitis C. There are also hepatitises D, E, and F, but you don't need to worry about those, okay? We're going to talk about A, B, and C, all right? So the viral hepatitis, here's what you need to know. Modes of transmission. Hepatitis A is oral fecal. In other words, you go to a restaurant and the cook hasn't washed his hands, or you're eating raw shellfish. Boom, hepatitis A. You can have hepatitis A, never be symptomatic, and it'll resolve on its own, right? Not a dangerous hepatitis of all the hepatitises. Children, believe it or not, are very likely to contract hepatitis A. Why? What do little kids do, right? Everything in the mouth. There you go. Hepatitis B, now that's the bad guy, okay? Hepatitis B is right up there with HIV. It's transmitted through blood and body fluid. In other words, blood, like if you share dirty needles, if you're a drug user, IV drug user, body fluids, in other words, sexual intercourse, okay? Same with hepatitis C. Hepatitis C, though, is treatable, far more treatable than B. B can actually kill you. But just remember, modes of transmission, Hep A. A is oral fecal. B and C, blood and body fluid, okay? They are the most common ones that we see in the United States. So prevention is the number one way to, avoid hepatitis. It's easier to prevent something than it is to treat it, right? So transmission-based precautions, we just talked about how they're transmitted. There are vaccines for Hep A and Hep B. You all know because you got hepatitis B vaccinations, series of 3, right? That is required when you are in the healthcare field. You're exposed possibly to it. You don't want hepatitis B, all right? So trust me. Signs and symptoms. This is kind of important because you're going to hear me use the word icteric, all right? So let's talk about the stages of the symptoms. The prodromal stage, and this, by the way, applies to any virus or viral infection. The prodromal stage is when you get actually exposed to it. You have flu-like symptoms possibly, and you might have right upper quad pain because that's where your liver is. The icteric stage, that can last up to 6 weeks, and that's where you become jaundiced, all right? That yellowing of the sclera, whites of your eyes, or the soft palate, right? So they're the places to look when you're looking for jaundice in a patient. And then the convalescent phase, which can last up to 6 weeks also, is hopefully a return to normal liver function. But if you hear me say the patient's sclera was icteric, their whites of their eyes were jaundiced. Okay, that's what that means. That's the icteric stage. Now, sadly, there can be complications associated with hepatitis, especially Hep B, things like liver failure. They can have a chronic infection that just does not resolve. And people that carry the virus can actually have an increased risk for cancer of the liver. Okay. Diagnostic tests, whenever we're looking at liver function, we're looking at liver enzymes, AST, which is aspartate aminotransferase, and it's 10 to 36, and ALT, which is alkaline phosphatase, 25 to 100 is normal. Okay. If the patient has a liver disease, you will see the liver enzymes, AST and ALT, elevated. Serum bilirubin should be 0 to 1.4. There's a conjugated bilirubin. Don't worry about that. We're talking about the total bilirubin. Total bilirubin. And bilirubin is the waste of dead red blood cells. Going back to the function of the liver, one of the functions is red blood cells go to the liver to die when they're old, right? They live about 120 days. They go to the liver basically breaks down the red blood cell, the hemoglobin, takes the heat, which is the iron, hangs on to it, and then discards what's left. That's the bilirubin. And normally it's excreted into the bowel and through the feces, so you don't even realize that you're excreting it. If you have liver disease, liver can't function properly, so that bilirubin spills back into your blood, which is what causes that yellow, jaundiced look. So with liver disease, total bilirubin elevated. Prothrombin time, PT, sound familiar? Yeah, I'm sure it does. That is about your bleeding time, one of the factors that has to do with clotting. If your liver is diseased, prothrombin time will be elevated, okay? Albumin. Albumin is a serum, it's a protein, right? Globulin protein in the blood. With liver disease, albumin will be decreased, okay? Because the liver, again, one of its functions is to synthesize amino acids, which are proteins. And if it's broken, it can't do that. And therefore, albumin levels will fall. So remember, with liver disease, AST, ALT, bilirubin, PT, elevated, albumin decreased, low, okay? And if we suspect liver cancer, we may want to do a biopsy, actually go into the liver and remove a piece of it to send to the lab, to pathology, to look and see if there are cancer cells there. The biggest post-operative or post-procedural complication is hemorrhage, okay? Because the liver is very vascular. So remember that. See how it's all in capitals? It means it's important. And then with hepatitis, therapeutic nursing interventions. What's the cause? Can we fix it? Monitor their liver function, relieve the symptoms. They're going to be tired. They need rest, hydration, nutrition, and they need to stay away from alcohol, which is toxic to the liver, and any other drugs like Tylenol, acetaminophen. Remember, hepatotoxicity is the big issue with that. Stay away, right? None for them. And we're not going to get into all the different types of antiviral medications. You don't really need to know that. There's some nursing diagnoses there. Acute pain, imbalanced nutrition, yada, yada, yada. With acute liver failure, that is sudden onset, right? A sudden massive loss of liver tissue. Do you know what the biggest cause of that is? Drug toxicity, Tylenol, right? Or hepatitis, especially Hep B, okay? So in other words, when somebody takes over the maximum dose, and remember the maximum dose of acetaminophen for an adult in a 24-hour period, 3,000 milligrams or 3 grams. They take more than that, they can experience just sudden acute liver failure. The liver just shuts down, okay? And that's a problem. But good news is the liver can regenerate. Only organ that can. With acute liver failure, you're going to have vague early symptoms, but it's going to hit like a ton of bricks. So what's going to happen is the patient's going to become suddenly jaundiced, yellow, hepatic encephalopathy. Hepatic encephalopathy is confusion, right? Delirium that is caused by increased ammonia levels in the blood. Back to liver function. The liver is supposed to excrete ammonium. When it's broken, it can't do that. The ammonium spills into the blood as ammonia. And then ammonia, as it's circulating through the blood at higher levels, crosses the blood-brain barrier, and it affects cognition. So in other words, the patient will present confused, agitated, combative, and these symptoms can get so bad that they can slip into a coma and die. And then also, patients with liver damage, liver failure, going to have bleeding. Why? The liver stores vitamin K, which has to do with your clotting ability. Your PT time, prothrombin, is going to be elevated, ability to clot. Fibrinogen is another issue with the liver. So if the liver is broken, you're going to have a hard time blood clotting, and that means you're going to be at risk for bleeding, just generally speaking. Okay? So they should be on bleeding precautions. And then the tests, that are associated. Remember that AST, that ALT, the bilirubin, the PT, those things are important. For people that overdose on acetaminophen, it's important to know that if it's really been too much time since they took it, we may have to dialyze them, right? Put them on dialysis, and we're going to get to more explanations about dialysis in GU, but just to keep them alive until we can get that acetaminophen out of their system and allow the liver time to rejuvenate. And then remember the antidote for acetaminophen overdose and acetylcysteine, okay? And then if the acute liver failure is due to alcoholism and they have increased ammonia levels, lactulose, which you guys just did, okay? With cirrhosis, 3.9 million, that's in 2015, mostly due to alcoholism. Cirrhosis, not always, but mostly, is due to chronic alcohol use. And cirrhosis is just basically progressive, irreversible replacement of healthy tissue in the liver with scar tissue. And that's usually irreversible unless early intervention occurs, just like everything else. The earlier you know about something and the earlier you treat it or intervene, the better the prognosis is for the patient, right? And like I said, alcohol is the #1 cause, okay? So with cirrhosis and chronic liver disease, again, it's the pathophys is that the liver cells get inflamed and they get infiltrated with fatty tissue and white blood cells, which now means that healthy liver tissue is scar tissue, okay? And the regeneration that's supposed to occur in those liver cells becomes abnormal, and the liver becomes a fatty liver. You've ever heard that expression before? And liver blood flow is impaired, liver function is impaired, boom. Here are the signs and symptoms, and I love this picture, for chronic liver disease, cirrhosis. You have the hepatic encephalopathy, which, behavioral issues, like I said, changes in cognition, disorientation, confusion, combativeness, agitation. You have portal hypertension. I'm not going to get into, all of it. You have a blood flow system that is kind of dedicated to the liver and the kidneys. And what will happen is, because of all the pressure and the liver impaired function, patient will have significant hypertensive issues. And I'm actually going to make this picture a little bigger so that you can see it. Skin's going to be jaundiced and they're going to be itchy. A lot of that has to do with toxins. When the liver can't filter out toxins, then they're spilling into the blood. If they're seeping through the skin, will get itchy. They're going to have possibly issues with diarrhea or constipation. Right upper quadrant pain. You may be able to palpate the liver underneath the last rib on the right side. Nausea. Their stools are going to look clay colored. Okay. And that has to do with a lack of the function of the production of bile. Bile is what makes your poopy look brown. If you don't have bile or enough bile, your feces will have a gray, like chalky consistency and color to them, okay? Loss of appetite, they don't feel like eating. They will have abdominal ascites, which is a retention of fluid in the abdomen. We like to look at it and call it a beer belly. Sounds cute, not cute. If you've ever known anybody that has a beer belly, it's hard, right? It's not fatty tissue, it's fluid that's trapped in the abdominal cavity, abdominal ascites, it's called. And it's a problem because it pushes on the diaphragm, makes it difficult for the patient to breathe. It's very uncomfortable. The patient will have things like esophageal varices, which are enlarged and dilated arteries, blood vessels in the esophagus, which can actually burst because of hypertension and bleed. So they can be bleeding out through the esophagus. I've seen that one time. Not fun. Not fun. Spider angiomas, which kind of look like spidery dilated blood vessels, usually on the abdomen, sometimes on the nose and across the cheeks, telltale sign. Their spleen will also be enlarged, hepatosplenomegaly, that's called. And we already talked about the bleeding issues. So whenever there's liver dysfunction, the patient is going to be on bleeding precautions because vitamin K, prothrombin, fibrinogen, they're going to have issues, inability to clot. Okay. And then here are all the things that I just talked about. Wernicke-Korsakoff syndrome. That is an irreversible hepatic encephalopathy. So in other words, yes, can lactulose reduce serum ammonia levels when the patient presents in the ER confused, agitated because they've been drinking, and they've caused damage to the liver, and now the ammonia has passed and gone to the brain. So we can give them lactulose as an enema to help draw the ammonia out of the blood, right? They're going to have diarrhea, but again, at least with that diarrhea is coming out the ammonia. Okay. However, that will only work but so many times. So there will come a time if the patient does not stop drinking, that those ammonia levels, even when we bring them down with the lactulose, irreversible damage has occurred with the brain, and they will have permanent, irreversible cognitive damage. That's Wernicke-Korsakoff syndrome. They will need to be probably in a facility, institutionalized because of it. Okay. There's a nice diagram. You can see the liver right there. It's up the right upper quad. And then there's this big portal vein, right? And it shows you the connection of the blood flow here with the esophagus, the spleen, and also, I mean, of all the things, this is the most minor, but they may suffer from hemorrhoids, all because of the pressure in this portal system. So all this pressure occurs. And when the blood pressure is that elevated, it causes all of these things to happen. Right? Diagnostic tests, pretty much the same. The liver enzymes, AST, ALT, bilirubin, serum ammonia levels, prothrombin time, et cetera, et cetera. Okay. Well, how do we treat the other issues? Like, for example, the ascites. Believe it or not, diuretics, right? Like furosemide. We're going to give them diuretics, hopefully to decrease the fluid retention. We're going to definitely restrict sodium intake. And remember, the magic number is about 1,500 milligrams daily. They may need an infusion of albumin because their protein levels may be so low that they're actually technically malnourished. So we may have to give them some albumin. Paracentesis, which is needle aspiration. We may need to stick a needle into the abdominal cavity to remove the fluid, draw the fluid out. Transjugular intrahepatic portosystemic shunt. That's a mouthful. It's an interesting thing. I've never seen it on a test, but FYI, we can put surgically a shunt into the portal system. So if you can see this little shunt or stent that's in place, that goes to a catheter that actually goes to, that's the aorta that you see, that big blood vessel, that actually can drain the fluid out, continually, so that the fluid does not build up, okay? And it reduces the pressure, that systemic pressure, okay? So just a fun fact. Esophageal varices, earlier I talked about them. So, when those blood vessels in the esophagus get so dilated and enlarged that they rupture, what do we do about it? Patient comes into the ER, there's blood, frank red blood kind of pouring out. Vasoconstrictors to constrict blood vessels. There are seal ligation, and ligation is basically tying up of the blood vessels to make them stop bleeding. They may need a blood transfusion, depending on how much blood they've lost. And we're going to prophylactically, to prevent infection because of all that open area in there, give them an antibiotic, more than likely. I've actually, that one patient in the ER, I had to do a tamponade. So basically, I took a Foley catheter. You heard me, a Foley catheter, urinary catheter. And you know how it's got the balloon, right? That has to be blown up with sterile water to keep it in place in the bladder. Well, put it down the patient's throat into their esophagus and blew up that balloon to put temporary pressure on the blood vessels to make the bleeding stop. It's a true story. Okay. And we talked about lactulose already. So there you go. And there are some nursing diagnoses, patient education, signs and symptoms to report. Worst case scenario, patient may need a liver transplant. If they are lucky enough to receive liver transplant, they're going to be on an immunosuppressive the rest of their life. The rest of their life. And cyclosporine, which is one of the drugs that we're going to be doing a med template on, it's an immunosuppressant. It's also known as Sandimmune. Need to know it. Okay. And there's some signs of rejection. I'm not going to go into that. I'm not going to get into cancer either, because we talk about cancer in its own lecture. So I'm going to fast forward ahead to yeah, not going to talk about that. Go to oh wait, I do want to talk about the colon sign. Hold on one second. So my bad. So liver transplant, cancer of the liver, signs and symptoms of liver cancer, the same tests we do there. But here we go. So this is acute pancreatitis. And that's where we're going next, okay? So your pancreas. Pancreas is an accessory organ for digestion. If you remember back in term 3, when we talked about the endocrine system, pancreas is an endocrine gland because it makes insulin. That's right. If you said insulin, you were right. But it's also an exocrine gland. And what it does is it produces enzymes, amylase and lipase. Lipase is a pancreatic enzyme that has to do with the metabolism of fats that you ingest. And amylase is about the metabolism of starches, carbs, okay? So with acute pancreatitis, which, by the way, usually because of alcoholism, right, the pancreas will become inflamed. And then this cool thing can happen. It's called autodigestion. The pancreas literally will eat itself. How, you may ask? And I've seen this once. So the enzymes that the pancreas makes, the amylase and the lipase, will be elevated. So much so that they are actually gnawing away at the pancreatic tissue itself. So the pancreas basically eats itself. Okay? When it comes to lab work, amylase and lipase, you need to know. Amylase 23 to 85, and that's a good indicator about pancreatitis. When you see the amylase elevated, they probably have pancreatitis. When you see lipase elevated, it's usually cancer. Okay, so it's in yellow. That means you should know it. Okay, alcohol, we already said that is the most common. Signs and symptoms of acute pancreatitis: abdominal pain, usually severe. People with pancreatitis will be in agonizing pain, and it usually will radiate either to the chest, the back, or the flank area. You'll see them guarding. The abdomen will be extremely board-like or rigid. Their blood pressure can drop so significantly that they can go into shock. All right. And then the other things like nausea, vomiting, their heart rate will go up, tachycardia, low-grade fever sometimes, and a shallow respiratory rhythm. One of the things that you do need to know is the colon sign. And there you go. It's periumbilical ecchymosis. In other words, around the belly button is black and blue. Okay, and there's a nice little picture right there. So periumbilical ecchymosis, which is a colon sign, is a telltale sign of pancreatitis, right? Diagnostic tests, here you go. We want to make sure that we're looking at, serum amylase and or lipase. They're the big ones. And let me highlight this right now because that's important. And they're usually greater than 3 times normal. Okay. And that's high. Therapeutic interventions, we got to give them IV fluids. When we say aggressive, it's like wide open. IV fluids. Nutrition. If the pancreatitis is mild, they may still be able to tolerate oral nutrition. If it's severe, they're going to be so nauseated that they're not going to be able to, so they will require enteral nutrition. They're going to need pain management, analgesics, and then antibiotics to prevent sepsis. Okay. We are now moving to chronic pancreatitis. Basically same thing as the acute, except with this, there's such significant damage with the acute pancreatitis that the patient will have an episode of acute pancreatitis, and then there's some damage done to the pancreas, and then they'll stop drinking, right? Giving you a hypothetical. Eventually, it will become chronic. It can also be due to obstructed ducts. It can be an exocrine insufficiency, which is genetic and rare, so we won't talk about that one. But alcohol abuse is the biggest reason. I can't even say it enough. Alcohol abuse is the biggest reason. So, prevention. I talk about this all the time. Prevention is always the best thing to do. Okay, and we're not going to talk about pancreatic cancer because, again, when we get to the cancer chapter, we're going to get into it. But I do want to talk about the Whipple procedure. And this you need to know. Okay, so that is a surgical procedure that is usually done because of cancer of the pancreas. But again, we have to find it early. Stage 4 cancer. No, but if we find it early enough, we can do a Whipple procedure. So this picture shows you 2 different approaches. The Whipple procedure can be a cholecystectomy. C-H-O-L-E, chole refers to the gallbladder, so you know. This is where the pancreas would be, okay? And so basically what we're doing is we're removing most of the pancreas, and then we're doing an anastomosis, either to the stomach, which gastrojejunostomy, pancreaticogenostomy, right? So basically we're removing the head and the neck of the pancreas, okay, which is usually where the cancer is. And the patient, remember, with most of the pancreas removed, no insulin, so they're going to be insulin dependent diabetic for the rest of their lives. Hopefully that the procedure does get rid of the cancer. Sadly, I will tell you that statistically, the Whipple procedure is not that successful, okay, but just something that you do need to be aware of. Okay, and that's enough of pancreatic cancer. Let's talk about the gallbladder. So remember, when we're talking about the gallbladder, chole, C-H-O-L-E, is referring to the gallbladder. Cholecystitis, inflammation of the gallbladder. Cholelithiasis, the word lithiasis is stones. So cholelithiasis is gallstones. Cholelithiasis are stones in the common bile duct. If you remember, when we looked at the anatomy, you have upper right quadrant, you've got the liver and the gallbladder, and they share ducts that go to the common bile duct because that goes to the small intestine to send bile to the small intestine. If there's a stone, a gallstone that's obstructing the common bile duct, that will cause inflammation and then subsequently infection of the gallbladder. Okay, so, and that's one of the more common things that can happen. Gallbladder disease, risk increases with age. It also increases with family history. If there is stasis, not moving bile, that's kind of stuck, because the gallbladder doesn't make bile, it just stores it. So if it's storing it and the bile can't move out of it, it will become inflamed. People with very high cholesterol intake, fatty diet, right? Believe it or not, this intermittent fasting, I know, is a thing now. I've seen it. Not healthy. Not healthy. because your body wasn't meant to fast. That's not how your metabolic rate works. And so fasting, especially, repeated fasting, like on a regular basis, is not healthy. And I'll talk more about that. If you have questions, you can ask me when we do our live Q&A. A sedentary lifestyle is also a risk factor. Sitting is the new smoking. Good news for me, because I don't sit. Sitting is the new smoking. Okay, when you do not move around, that puts you at risk for so many things, including gallbladder disorders. And for some reason, statistically, women are affected more frequently than men. Signs and symptoms. Well, silent stones, what that means is there's a stone that's kind of lodged either in the gallbladder or in the common bile duct, and you don't really feel it, but you'll have some minor symptoms like vomiting, nausea, some mild epigastric pain, which is right here, indigestion. You may have right upper quad tenderness, okay? A positive Murphy sign, which we're going to get to in a second, and then biliary colic. Biliary is of the bile duct, okay? So that's colic is intermittent pain. So biliary colic is the patient's going to have pain that comes and goes right in that area, right around the right upper quad. Here is the Murphy sign. You have your patient lying down, you ask them to exhale. You put your hand right at the costal margin on the right side of the mid-clavicular line, okay? And then tell them to take a deep breath. When they do, you're going to see the face. They're going to, it hurts. That is a positive Murphy's sign. That means the gallbladder is enlarged, it's inflamed, and what's happening is you actually will be able to feel it when the patient breathes in, because the expansion of the lung kind of pushes the gallbladder forward and it hurts the patient. So cholecystitis, that's a positive Murphy sign. If we don't do anything about gallbladder disorders, they can lead to things like cholangitis, which is the blood vessels of the gallbladder can become inflamed. Necrosis, death of gallbladder tissue, perforation, rupture of the gallbladder, which leads to empyema, in other words, purulent exudate, pus that can be kind of pouring out into the abdominal cavity, can lead to fistulas, adenocarcinoma, cancer of the gallbladder, and acute pancreatitis. Diagnostic tests. Usually we can quickly do an ultrasound to see if that gallbladder is really that enlarged, if it needs to come out. And gallbladder surgery, cholecystectomy is what it's called, is a common procedure. We can do it different ways. Laparoscopic surgery is least invasive. Traditional is also called open, okay? So if we do a laparoscopic cholecystectomy, what we're doing is we're making these little kind of puncture wounds in the abdomen, and through those puncture wounds go a scope, the laparoscope, that's like a camera, you can see inside, and then through the other puncture wounds go the surgeon's tools, like a scalpel, etc., forceps. And we go in, we can visualize the inflamed gallbladder, we can actually cut, remove it, and usually it's a very easy and quick healing process with a lap chole because it's less invasive. When we have to do a traditional or open chole, and I need to put that in here, traditional surgery, open, the patient will have a T-tube. You need to know this. Need to know it. A T-tube. And a T-tube, basically we call it a T-tube because it looks like a T. So if you look at the picture, it goes in through here into the common bile duct, right? There's the T part of it, okay? Here's the gallbladder that's been removed. There's the incisional site on the outside of the patient's abdomen. And this T-tube actually exits out through the abdomen and into a drainage bag, okay? T-tube is usually in place for several days after an open cholecystectomy. And it's important to know that it should be emptied daily at the same time every day. The drainage would be bile. So you'd be looking at something that's kind of a yellowy, greeny, very lovely color. And of course, you would be documenting the amount that's draining from that T-tube. And then the T-tube is usually removed after 2-3 days. Sometimes it's not so bad. We can use medication to medically manage the situation, dissolve the stones, but that's not common. Not common. There are the nursing diagnoses that go along with gallbladder issues. And then the other thing I do want to talk to you about real quick is that, remember, the gallbladder stores bile. The liver makes it, the gallbladder stores it. When you eat McDonald's, and I'm not hating on McDonald's, I like me a Big Mac, or a Burger King, or any type of fatty meal, okay? Your gallbladder releases the bile into that common bile duct that goes into the small intestine that helps you metabolize and absorb that fat, okay? After your gallbladder is removed, you have to make sure the patient understands. It's not that they can't ever eat a fatty food. Again, we need some fat in our diet. Blood-brain barrier is made of fat, right? There's a fatty kind of a barrier right at your flank area that protects and cushions your kidney. So you need fat in your diet, good fat, a little bit. So after a cholecystectomy, they need to incrementally start introducing teeny tiny amounts of fat into their diet, okay? Teeny tiny amounts, because if they eat a Big Mac, they're going to have terrible, terrible abdominal pain, and they're going to have steatorrhea. Steatorrhea, which is diarrhea, but fatty. So in other words, the fat that they've eaten can't be metabolized because there's not enough bile. And so it goes right through their digestive system. And when it comes out, it's pretty cool because it floats in the water in the toilet, right? The steatorrhea. It's basically the fat just going right through, okay? You need to know steatorrhea, and you need to understand the teaching post gallbladder removal or cholecystectomy is to introduce fats in teeny tiny increments and very slowly after that surgery. All right, we got some review questions here that you can kind of look at and do, and that's all for now. So I'm going to stop my share, and then we're going to do Q&A, and then until next time, see ya. Bye.